Perfect. All right, guys. Well, welcome for our medical student education group webinar. So we're going to have two of these this summer. So today's is we're going to talk about some different cases just to give you guys a sense of what are some of the crazy things that we deal with. Um, August 6th, we're going to do an introduction to vascular surgery. We'll have a bunch of presentations about different aspects of the application process. What is it that we do? What do we cover? And then, oh, Angela, we just lost your screen. But lastly, and most important, at the MVSS meeting, we have a really fun simulation course, so we hope to see you guys there. For the purposes of tonight, we're going to have four speakers that are each going to hopefully stay to about 10 minutes, talking about some interesting infectious complications. If you guys have questions, please use the chat. We'll try to respond sort of throughout. And please enjoy. Our first speaker is going to be Dr. Sharma from the University of Nebraska, talking about an infected aortic aneurysm. Go ahead and share.
Sharing. Are you guys able to see the screen now? Okay, so good morning. I'm one of the fifth year, good evening. I'm one of the fifth years at UNMC, still waking up. For our first case, we have a case of an EVAR graft infection by M. bovis that happened after BCG therapy, and that was diagnosed with a Carius test. So before I go into the case, a little bit introductory background for the medical students here. So for EVAR graft infections are pretty rare group of infections. They are usually difficult to diagnose, and untreated infections can be fatal. One way of categorizing them is early graft infections usually happens less than 3 to 4 months. And these are caused by highly virulent organisms like the gram-positive ones, the Staph aureus, gram-negative ones listed here, E. coli, Pseudomonas, etc. And the late graft infections typically happen later on, greater than 3 to 4 months, and usually caused by low virulent organisms. Salmonella is one frequent pathogen that shows up, other ones being staph epidermis and atypical organisms. Usually for these, for that method of diagnosis, blood cultures, or if there is an abscess pocket, you can take a culture from there. They usually come back positive, but especially for atypical organisms, these cultures can be frequently negative, and you have to obtain tissue samples and a culture from actual tissue biopsy to get, a positive diagnosis. Curious testing is actually a blood test. It's a type of a next generation sequencing test where you take the blood sample and test analyzes about closer to 1,000 different blood pathogens based on the microbial cell-free DNA. And BCG, you all know, is a live attenuated strain of M. bovis. It's used as a therapy for bladder cancer and can cause a primary aortic infection. So for our case today, this gentleman was 72-year-old male who presented with a 6-month history of 40-pound weight loss and anorexia. No reported fevers. He did have significant medical history of bladder cancer that was treated 4 years ago prior to presentation with a partial cystectomy and intravesical BCG. And his surgical history was significant for aortic aneurysm repair with EVAR with the Endologix AFX2 graft. That was 2.5 years prior to presentation. So when he came in, workup was done. He did not have any leukocytosis. On his axial imaging with CT, there was an 8 centimeter psoas abscess with possible aortic sac communication. He did get blood cultures that were all negative. He got a drain in that abscess, cultures from that drain that were also negative. He did get a PET scan that had extensive perigraft uptake. And while, we did other workup for atypical organisms per involving our infectious disease specialist of TB, Q fevers, and other atypical organisms listed there, which were all negative. And we, in the end, also performed this NGS testing, the Carius test, and on the day of operation, it resulted positive for Mycobacterium tuberculosis complex. And we did test, pulmonary samples, sputum samples for AFB, which were negative for the typical Mycobacterium tuberculosis, pointing more towards M. bovis as the source of infection. So this is his, imaging. You can see the CT on the left. There's about, abscess in the psoas, which communicates with the aortic aneurysm sac. You can see the graft and EVAR. And on the figure on the right, you can see PET scan. There's extensive perigraft uptake, FDG activity. You can see the IR drain over there in the psoas abscess. So, he was worked up. We did the workup for potential infectious sources. His nutrition was optimized. And on day 11 from presentation, he was taken to OR. And the surgical intervention that was done was we did extensive aortic wall debridement and explanted the prior EVAR graft and did the reconstruction in situ with a rifampin-soaked Dacron bifurcated graft and protected the graft with an omental patch. Uh, since we had positive Kirius testing on the day of operation, within that night he was started on anti-ATT empiric therapy with isoniazid, rifampin, and ethambutol, and he did well and was discharged 8 days later with no complications. From tissue cultures that were obtained in the OR, the aerobic and anaerobic cultures were still negative. The AFB cultures were positive at 3 weeks by PCR. On his 18-month follow-up, he's still doing well. There's still SAC regression on surveillance CT scans. There's no infection recurrence. And the planned ATT therapy is for 1 year empirically per our ID colleagues. So overall, this is a rare case. M. bovis is a rare cause of vascular graft infection. Only, 19th case reported in literature, and this was one of the first cases done using this special technique that was established the diagnosis. Uh, what was special about this was based on that we were able to start empiric antitubercular therapy much earlier. Yeah, as you know, like even if you send tissue cultures from OR, they can take up to 6 weeks for the AFP culture to turn positive. Like in our case, it required 3 weeks, but we were able to start therapy much earlier based on this NGS testing. Another important discussion point, especially when you're thinking of vascular graft infection by atypical organisms, you need to have a heightened suspicion because there could be just non-specific signs and symptoms, and diagnosis is usually hard to establish. Uh, you should think about prior BCG immunotherapy in these cases, especially if it's hard to establish a diagnosis and traditional testing has been negative, which can be complicated by, some of these newer techniques uh, involving next generation sequencing. That's it. We can take questions and have discussion about this.
Thanks for that. Do you guys have any questions? I'm just looking, our chat, I'm wondering if we have the correct chat thing set up. So my chat thing says it's to hosts and panelists only. So um, I'm worried if you guys are sending something in the chat, I may not see it. Can someone write something in the chat and see if we can see it?
I just wrote something. Can you see me?
Yeah, I can see you. What about one of our attendees here? Okay. I saw Armin put his hand up. Okay, well, we may have to work on the chat. Oh, chat is disabled. Got it. Oh, here it is. Okay, but we have the Q&A thing, so at least we can use that. So let's use the Q&A instead of the chat. Perfect. All right, anything for the Q&A, or we can move on just for the interest of time to stay on track. let's move on for Dr. Cohen, who's going to talk about an infected diabetic foot wound.
Okay, give me one moment while I share this. Okay, you guys all see my screen.
Yes, we can.
Okay, excellent. So good evening, everyone. My name is Manuel Cohen. I'm one of the second-year podiatry residents at McLaren Health System. Zishan Hussein is our program director for podiatry, is not unable to make it tonight. Dr. Mawad is our vascular specialist, and he also got tied up tonight. He's a busy man. We spent a month with him, and it was very busy. I did 90 cases in 1 month with him. So he's probably in the OR somewhere. But he reached out to me about doing showing like the collaboration we have between podiatry and vascular in some of these infection cases. There are no financial disclosures. So these are our goals. We talk about diabetic foot infection management in the setting of concomitant ischemia, critical limb ischemia, or CTO. So this came into my ER. A 69-year-old male comes in. He had this scab on the lateral aspect of his right foot, and he kind of picked at it, and then it turned into this wound, and it started smelling bad, and then his toe turned black. And you can't see it on this view, but there's another blister on like the plantar medial aspect of his foot. He's not such a healthy guy. His A1C is a little elevated. He's got heart disease, lung cancer. He's still smoking. He's still smoking now to this day. This was 2 years ago when we first saw him. So I go in to see him, and there's streaking and erythema up the leg, and you want to always check if it blanches, and if it's dependent. So if you raise the foot up, does it fade? And it didn't, and that usually means it's an infection if it's not blanching. I could not feel any of his pulses. There's just Alicepetus or posterior tibial. Sluggish cat fill time. He obviously has this dusky, almost necrotic appearing fifth toe. And then the infection aspect. So it was an odorous wound. It probed down to bone. And then his white count was 22 and a half, and he had an elevated heart rate. So that's 2 out of 4 SIRS with the source. His respiratory rate was fine, and he didn't have a temperature, but he subjectively was feverish. So the next thing we do in the situation is we get an X-ray to rule out something called gas gangrene or necrotizing fasciitis. So if you can appreciate here, there's some cortical erosions, and then these little, I don't know if you guys can see my cursor, but these like little lucent areas, these focal lucent areas on the radiograph. This is soft tissue emphysema, free air, which is a sign of an aggressive infection. They like to travel up the tendons and get more proximal. And this can be limb threatening and life threatening if it's not treated in an urgent, sometimes emergent fashion. So, and he was symptomatic. He was septic. So we took this guy for a washout right away that night, and we resected the fifth ray, washed it out, left it open, and then now you can see that plantar medial blister. So we opened that up too, and the best antibiotic, I was told once, is surgery. So, cut it out if it's infected if you can. So remove the infected bone, you send that pathology to see if that comes back as infected, and that's going to determine your antibiotic route and duration. So if you have residual osteomyelitis, you're looking at 6 weeks IV antibiotics. We culture it as well. We always cover them empirically because it's foot, so you got to cover for Pseudomonas, anaerobes, so usually vancomycin and zosyn, assuming that they don't have kidney disease. Then comes the vascular workup. So I don't know if you appreciated here, you can see that there's Alicepetus arteries calcified, and on the lateral you can see his posterior tibial arteries calcified. There's anterior tibial artery. It doesn't have palpable pulses. So we consulted vascular, and they started the vascular workup. So he's all monophasic, pretty much distal to popliteal, anterior tib, posterior tib, peroneals. And then his ABI TBIs are elevated, but obviously they're going to be elevated because his vessels are calcified. So, and the vascular specialist here can tell me how they feel, but you all really just tells you you need to do more testing, right? Because it doesn't, all it tells us is they're calcified and that this, your ABI TBI is not going to be accurate. So the next step, Vascular did a CT angiogram and it showed a CTO in the posterior tibial artery at about like the mid calf area. Then they took the patient for an angiogram, and the angiogram showed that there was reconstitution from collaterals distally at the pedal arch. So there was good flow, but because his toe was so dusky and they were thinking about critical limb ischemia, they decided to do intervention. So it did a balloon angioplasty and it placed a stent in that posterior tibial artery, which opened it up. And I should have put a slide in here about angiosomes, but for the medical students, so the angiosomes are what areas of the body or the foot in this respect are supplied by what vessels. So our wound was plantar lateral. So the plantar aspects supplied by the lateral plantar artery, which comes off the posterior tibial artery, which is what was occluded in this case. Yes, we're getting some supply from the peroneal, but we can maximize it more. So that was kind of the thought process as to why we opened this up, even though we still had two vessel flow to the foot. So now that vascular has been opened up and optimized, we took him back to the OR because we basically you only do what you need to stabilize the patient initially in the setting of infection, and then you wait for to establish flow. So we debrided the wound. There was good bleeding this time. We didn't have really any bleeding the first surgery. The fourth metatarsal head was exposed at this time, so remove that as well. And we put on a little bit of graft product and put him in a wound vac. Then we started seeing outpatient at wound care, and it's decreasing in size. It's a little fibrotic looking, but it doesn't look, it's not infected, didn't smell. You can see on the radiographs that we took the some of the fourth met, but left the digit. This is after debridement in the office. And so he was progressing along very well, was healing nicely. We'd optimized his blood flow. He was still smoking, but it's always the smokers that heal. The people don't smoke and have vascular disease, like they don't heal. And this guy's smoking a pack a day for 50 years and he's healing. But then he kind of gets lost to follow up. He returns and he's got this like necrotic hallux now. And the other area has really healed up. So we send him to the ER, we get x-rays, and there looks like beginning of osteomyelitis on the hallux. And this now shifts to like a biomechanical consideration, like levels of amputation. So once you start removing one or two digits, it sounds crazy to think this way, but like the foot is more functional with the transmetatarsal amputation. So a more functional foot. So that is really the next step here. If we wouldn't ideally just take the hallux, and now we're also missing the fourth and fifth ray, basically. So transmetatarsal was the next step we did here. And then we put him in a total contact cast, which is like we like to do in Pontiac because they don't have such a compliant demographic. So basically this forces them to stay off of it. They can walk in this cast. We put this blue stump here. And we've had a lot of success. But this guy, we casted him weekly for, I don't know, 12 weeks for him to heal this thing. Every time we would like trust him to take off the cast, it'd be worse the next week because he would just walk all over it. Then he developed another wound, plantar lateral. I'm not going to get too into the weeds with all this biomechanical stuff, but basically his Achilles tendon was contracted. So he's putting a lot of pressure on the distal aspect of his TMA stump. And his peroneals, so his everters were weak and his inverters were strong. So basically his TA and his PT were inverting his foot. So we basically took him back to surgery. We debrided this little like exostosis on the distal fourth metatarsal that we thought was maybe causing the wound. We linked his Achilles tendon, and we took some of TA, and we transferred it to the midfoot. So what that does is he still has plantar flexion, but he loses his inversion. And this is so he gets a stable plantar grade foot. Go back to total contact casting. And since this time he has healed all of this. This is just the last clinical picture I have of him. So he healed everything. He has a stable plantar grade foot. He's functional. Infection's gone, and he's as optimized vascularly as he can be. So this was a win for us. He didn't lose the leg, and the infection didn't spread proximal. So in summary, initially infection control if they're a septic patient and there's an active infection and it's wet gangrene, not dry, you take them right away. Whoever does it, vascular, podiatry, ortho, it doesn't matter. Control the infection, then optimize perfusion, then do additional intervention, wound care, biomechanical rebalancing as needed, to kind of bring it all together. So we look very closely with vascular in this one. They were seeing the patient, we were seeing the patient in constant contact. Thank you. And are there any questions?
I have a question while we wait to see if there are others. When do you decide when to put a tissue matrix on, especially in an infected or a potentially infected field?
So if it's stalling out and it's not healing and we've got blood flow, that's when I start to consider like these tissue products. Also, if I don't think that I'm ever going to see this patient again, like this guy was lost to follow-up multiple times, then I will like overly put on a product before they leave just to give them the best chance. But if it was a regular compliant patient, I would wait to see that the wound's not improving, 25% every week, and before considering that.
Yeah, I would just say that it's interesting in this case that it worked since it was only a couple days.
Yeah, they put it on, and it's the stuff they use. It's Axiofill, and they have it on the shelf, and so a lot of times we'll just put it on. But if we're doing something like a Epifix or a graft that we have to order, we're a little more selective and more costly. Yeah.
That was actually going to be part of my question and this is, I mean, to the faculty maybe on the call as well. What is your go-to kind of matrix? I've had some partners who love Kerecis, or, Graphics or Stravix, where you can put some of that on the clinic versus the OR. What are people using for those matrices?
So I've used Stravix, I've used Epifix, I've used Kerecis. I haven't really seen an advantage or disadvantage to any. We kind of just try and use everybody who's local. Certain attendings have certain preferences. So the attending who was doing this case is a big Stravix fan. But I don't know if anybody else has
We've
found
done some
anything.
work with Novazorb, the BTM system, and that has worked pretty well. We usually use it more for coverage than anything else. It tends to prevent a lot of the weeping. So, okay. Well, let's move on just to stay on time. Obviously, we can still use the chat. Next, we have Dr. Rahman from MCW talking about an infected Dacron carotid patch.
Hello, everybody. Let me see if I can get this working. Okay. Can everyone see my screen?
Yes, we can.
Okay, thank you. So, my name is Rahman, and I'm an M1 at the Medical College of Wisconsin. And today I'll be presenting a case of a chronically infected bilateral carotid Dacron patch complicated by pseudoaneurysm formation and sentinel bleeding. So before getting into the case, I want to briefly review carotid and endarterectomy, or CEA, since that forms kind of the basis of this patient's pathology. Basically, CEA is a surgical procedure where atherosclerotic plaque is removed from the carotid artery to reduce the risk of ischemic stroke. The idea is that these plaques can embolize and significantly limit blood flow to the brain. So removing them improves cerebral perfusion. It's typically performed for symptomatic stenosis or severe asymptomatic disease, and contraindications include complete carotid occlusion or large disabling stroke, where basically the risks outweigh the benefits. There are basically two main techniques. Let's see if I can use my laser pointer. The conventional longitudinal approach, which is here, and then the aversion technique. And in the conventional approach, the artery is often repaired with a patch to widen the lumen and reduce restenosis. These patches can be made from bovine pericardium, autologous vein, or synthetic materials like Dacron or ePTFE. Synthetic patches are commonly used because they're durable and easy to handle, but they do carry a very small risk of infection. And although the infection occurs in less than 1% of cases, it's important because it can present years later with pseudoaneurysm formation, chronic sinus tracts, and even rupture. And that's kind of the process that we're seeing develop in this patient. So, this patient is a 80-year-old female with hypertension, hyperlipidemia, chronic kidney disease, type 2 diabetes, as well as bilateral carotid stenosis treated with CEA. The left one was done in 2003, and then the right one was done in 2006 at an outside hospital. Her post-operative course was complicated by chronic bilateral draining, sinus tracts, requiring multiple prior debridements. That was done in 2008 and 2015. And then in this image, this is what she's presenting with was 10 days of intermittent bleeding from the right neck incision site, which acutely worsened. She woke up with blood soaking her neck and had an estimated 200 cc bleeding episode that was controlled with compression. So based off of her history, this was highly concerning for a vascular complication. So in patients with prior carotid or prior CEA presenting with delayed bleeding, the leading concern is an infected carotid pseudoaneurysm. It's been seen that delayed hemorrhage after a CEA is most commonly associated with infection or pseudoaneurysm formation. So given this patient's history and prior infections, that was our leading diagnosis. This is especially likely given the history. And so some other vascular causes include patch dehiscence, where the prior repair breaks down, or a carotid cutaneous fistula, where there's direct communication between the artery and the skin. Importantly, this type of presentation can represent a sentinel bleed, which may precede a catastrophic carotid blowout. And some less likely causes would include superficial wound bleeding or tumor-related bleeding based off of the history of Werthin's tumor, but these are less consistent with the volume and description of the bleeding in this case. So given this presentation, the patient was treated as having a potential vascular emergency until proven otherwise. She remained hemodynamically stable and neurologically intact, but the priority was identifying the source of bleeding. Initial workup focused on vascular imaging, starting with CTA here of the head and neck to evaluate for pseudoaneurysm or vessel disruption. This was followed by diagnostic angiography to better characterize the lesion and evaluate intervention options. So here, in terms of our angiography, the CTA for the symptomatic right side, basically, you can see that there's the occluded ICA stump, which is a new finding since 2014, and adjacent to that is the pseudoaneurysm, and this tracks superficially toward the skin, consistent with the chronic sinus tract communicating with pseudoaneurysm. There's no active contrast extravasation, although the lesion remained high risk for rupture. The left side also demonstrated chronic pseudoaneurysm without acute rupture because there was no active bleeding and there was robust collateral circulation supplying the right MCA and ACA territories. Embolization was not performed and the patient proceeded to surgical treatment. So Given the infected pseudoaneurysm and ongoing bleeding risk, the patient underwent urgent surgical exploration. And so intraoperatively, there was significant inflammation, scar tissue, patch dehiscence, and friable carotid tissue, making primary repair unsafe. So the infected Dacron patch and pseudoaneurysm were excised, and the already occluded right ICA was ligated. Reconstruction was then performed using a reversed saphenous vein graft from the common carotid to the external carotid artery. And reversing the vein ensures that basically the one-way venous valves don't obstruct blood flow. And then this allowed removal of the infected prosthetic material with the Dacron patch while still maintaining cerebral perfusion through collateral circulation. So there are three intraoperative specimens that were obtained. Those included pseudoaneurysm capsule, carotid patch, and then surrounding fluid. The cultures grew Streptococcus aeruginosus and Actinomyces species. And based off these, this suggests a chronic indolent infection likely driven by Actinomyces, which is known to cause sinus tract infection. And this was likely complicated by a superimposed acute infection with Streptococcus, leading to the tissue breakdown and her acute bleeding presentation. So post-operatively, the patient recovered well from her right-sided repair with a patent bypass and no neurologic deficits. She completed IV antibiotics and was transitioned to long-term suppressive therapy. Her right neck incision healed appropriately. However, she did develop right vocal cord paralysis, and this is likely due to recurrent laryngeal nerve injury, just due to anatomy. And she also continued to have persistent disease on the left side, including a chronic sinus tract and known pseudoaneurysms, as we saw in the angiography findings. So over time, her left-sided disease progressed with development of an exposed Dacron patch and new sanguineous drainage. However, given her prior nerve injury and contralateral ICA occlusion, she was considered high risk for another open reconstruction. So instead, she underwent transfemoral carotid artery stenting to exclude the pseudoaneurysm, along with pectoralis muscle flap coverage. This represented a shift from definitive surgical management toward a more conservative risk reduction approach with continued surveillance and chronic suppressive therapy. So this case highlights several key surgical principles in managing these infections. Basically, the primary goal is to have complete removal of infected prosthetic material, along with wide debridement of infected tissue. Reconstruction should be performed using an autologous conduit when possible, such as saphenous vein graft, to reduce reinfection risk. Maintaining cerebral perfusion is critical, and ligation is acceptable if the vessel is already occluded or there is sufficient collateral flow. Adjuncts such as muscle flap coverage and long-term antibiotics are often necessary for durable management. So basically, in summary, carotid patch infection is a rare but potentially life-threatening complication that may present many years after initial surgery. Chronic sinus tract formation should raise a concern for underlying graft infection, and new bleeding should be treated as a sentinel event for possible carotid blowout. Management requires a balance between definitive surgical treatment and risk-adapted approaches, as we saw here, and that depends on patient factors and history. So overall, this case highlights kind of that complexity of managing infected vascular grafts and also the importance of individualized decision-making. So that is all I have for you guys. Thank you, and I'm happy to take any questions.
Thank you for that. That was very interesting. Tell me about the selection of the stent for the left side. Did you use a bare metal or a covered stent, and how might that change the long-term infection risk?
So the selection of the stent on the left side, correct?
Yeah.
Yeah. So sorry, Efra did a great job. She's a first-year med student, is very interested in vascular. So we did a covered stent on her on that side. She at this point is 84 years old, and was completely against having a tracheostomy, and obviously did not want a stroke. And so we were kind of balancing kind of a surgical reconstruction. So had to do a covered stent. So she's going to be on suppressive antibiotics. She only grew Staph aureus from her contra side, interestingly. So
No, I mean, I think there's some literature out there now that you can use covered stents with muscle flaps and debridement with suppressive antibiotics, and people do okay, especially in the carotid world.
yes, yeah. So that's what we're kind of going off. And I sat on her for probably 2.5 years between sides, and we were just staring at the left side. So very, very nicely presented out for a very complex patient.
Do you excise the sinus tract at the time that you did the redo right-sided exposure?
Plastic surgery did. Yeah, they kind of took out the abnormal soft tissue there. I should have had Afra include a picture of it, but she's had a very nice flap coverage there, and recovered well. And interestingly, her vocal cord injury, she never had really major symptoms. But before I would ever do a contralateral redo, I have ENT see all these patients and assess their vocal cord status.
Yeah, no, it's always interesting whether that's from your case or not then, because potentially it predated your redo exposure.
100%, because yeah, I didn't see her pre-op for that. But yeah.
CK.
Perfect. Well, let's stay on time. So the last one is Dr. Armstrong from Ohio State talking about infected tibial pseudoaneurysms.
Great, let me share. My name is Molly Armstrong, and I'm a medical student at The Ohio State University. I'm excited to share with you all our case of an infected pseudoaneurysm of the tibioperineal trunk as a presentation of endocarditis. So this is the case of a 73-year-old male with a history of bicuspid aortic valve replacement, thoracic osteomyelitis, and culture-negative endocarditis that was complicated by TIA and splenic infarct, who presented with right lower extremity swelling and intermittent rigors and chills. He was initially diagnosed with a DVT at an outside emergency room and treated with warfarin, but his symptoms didn't resolve and the swelling did progress, and a posterior pulsatile calf mass was then noted by his PCP, which prompted further workup and referral to vascular surgery. So he was first evaluated at an outside practice that did a right lower extremity angiogram, as pictured here, that demonstrated this large tibioperineal trunk pseudoaneurysm. Extensive infectious workup was ordered, including white blood cell scan and ID consult, and at this point he was transferred to our tertiary care center for further management. So he was taken to the OR for ligation and excision, which began with this medial exposure to obtain control of the popliteal artery proximally. There was quite a bit of significant surrounding inflammation, so it was difficult to obtain circumferential control distally, and instead, a tourniquet was placed proximally, and then the pseudoaneurysm sac was entered, and a pruit was actually placed into the artery for distal control. This allowed for ligation of the TP trunk, both proximal and distal, to the pseudoaneurysm capsule, and once excised, it was sent for a culture. So here we have completion angiogram images. So first on the left, you can see the patent popliteal and anterior tibial arteries. And then the next image shows reconstitution of the PT and perineal arteries via collateral circulation. And then lastly, we see distal runoff that confirmed adequate blood flow to the distal extremity. Next, given his history and for suspicion of embolic etiology, we did an intraoperative transesophageal echocardiogram, which demonstrated a large vegetation on the aortic valve. So then his postoperative course did involve quite a bit of collaboration with our cardiac surgery team. He then underwent standard aortic valve replacement workup, which for him included a diagnostic cerebral angiogram, especially in the setting of him having a prior TIA. We wanted to rule out cerebral mycotic aneurysm, and then which was negative, and so he underwent redo valve replacement. The valve cultures did grow Cutibacterium acnes, which was consistent with occult infection and probable septic embolization. He did well postoperatively and was discharged on doxycycline and ceftriaxone. He did well at both his 1 and 6 month post-op visits with just some residual foot and calf numbness, but this was actually present prior to surgery, and his pulses were palpable both pre and post-operatively as well. Our infectious disease colleagues also followed along with his post-operative care, and his infectious workup was rounded out with a tagged white blood cell scan that fortunately was negative for any ongoing infection. So just for some teaching points from our case, so specifically for my fellow medical students here, this figure really illustrates some of the key differences between true aneurysm that involves dilation of all three vessel wall layers versus a pseudoaneurysm, which results from disruption of the intima, media, and sometimes even the adventitia, which allows for bleeding into the surrounding tissue while also maintaining communication with the true vessel lumen. So that really poses a higher rupture risk as well. And given our clear infectious history, pseudoaneurysms tend to be the favored diagnosis because the infectious process destroys the vessel wall from the inside out, resulting in disruption rather than uniform dilation. Some other causes of pseudoaneurysms that you might see in the literature are iatrogenic or trauma-related or even rheumatologic. This is clinically significant as pseudoaneurysms carry a higher rupture risk, and additionally, with all this in mind, if there is uncertainty, pathologic examination can confirm the final diagnosis postoperatively. Next, when considering management options, endovascular intervention, including coil embolization, can be appropriate in cases where there's a lower clinical suspicion for infection. And then this figure here just kind of walks through some of the other options. So coil embolization as well as stenting and even thrombin injection can be used. However, in our setting, coil embolization had some important limitations as it doesn't address the underlying infection, which can then just lead to ongoing tissue compromise. Additionally, the presence of foreign material just introduces another nidus for ongoing infection, and ligation and excision allowed for the most definitive source control. Importantly, too, in our case, completion angiogram demonstrated distal collateral circulation, which can guide our intraoperative decision-making regarding the need for revascularization. So lastly, infrapopliteal pseudoaneurysms can really present with features that initially mimic more common conditions such as DVT, like unilateral leg pain and tenderness, erythema, and swelling. But when suspected, a pseudoaneurysm also carries broader diagnostic implications, especially in a patient with a prior infectious history and valve replacement. Notably, pseudoaneurysm is considered a minor criterion for infective endocarditis under the modified Duke criteria, and as a result, identification of infected pseudoaneurysm should prompt thorough evaluation for an embolic source, including workup for endocarditis. Thank you all. I'm happy to take any questions.
That was very interesting. Can you tell me why you guys elected to not reconstruct?
Yeah, I think I can go back to the angiogram images here too. So we could see that he had pretty good blood flow to his distal extremity, so there wasn't necessarily a need for that. And there's also a risk at kind of inserting anything into an already infected field.
And why do you think it would have been there? Is there anything about the vasculature that would result in that location being susceptible?
I would say just because of how, since it's so distal and then it being kind of like a trunk or bifurcation, that could be particularly susceptible to embolization.
Yeah, I think that's the key. I mean, t things tend to lodge at bifurcations, and so that's usually the cause. And it's usually just based on size, right? So this was something that got through many other bifurcations. It got through the iliac, the common femoral, the distal pop, right? And just based on size, it fell and hit that spot. But I think it's always important, to think about things outside of our territory, right? Like looking at the aortic valve or the mitral valve for potential causes of these things. So very interesting. I have not seen one of those, thankfully. Although we do get plenty of patients with endocarditis. Do you know what the literature shows on something like this? Is there a
There,
significant
yeah,
amount?
there are some cases. I can't remember exactly what number ours was, but it's quite rare.
It would be interesting to publish.
Mm-hmm.
Okay.
Great.
Anybody have any other questions? Angela, are you still on? Are you able to show your slide for the August date again? Can send her a message. But for all of you guys on the Zoom for August, we'll have another discussion just about the different types of pathways, whether it's integrated versus fellowship, things to look out for. And then most importantly, we want to see everyone at the MVSS meeting in Chicago, where we'll have a really fun simulation session, bringing out some different things that you guys can sew by hand, and also some different simulators that we can play with. And so looking forward to seeing you guys all there. So
And
thank
there
you.
are some scholarships available for that too, so please apply for those.
That's true. Yes, we do have the travel scholarships. So you will see an email about that. But I also want to thank all the speakers who kept time, kept us within our hour, which is wonderful. We didn't have to shut anybody down or figure out how to, which we always appreciate. So thank you guys for giving those little presentations. All right. Well, with that, I guess let's go ahead and close out. And thank you guys all. You guys all have about an extra 10 minutes of your evening.
Thank you. Thanks for having me.
Thank you.
Thank you.